Welcome, everyone. Thank you for joining us. Our webinar today is entitled NutrEval and ION, Case-Based Interpretation for the Athletic Patient, and our speaker is Dr. Warren Brown. My name is Dr. Lenore Powell, and I'm a medical education specialist in Genova's Atlanta branch. I'm going to serve as your moderator for today's webinar. We would like to welcome Dr. Warren Brown. Dr. Brown earned his doctorate degree from the School of Naturopathic Medicine at Bastyr University in Seattle, Washington. He then went on to complete an 18-month clinical residency program in Tacoma, Washington. Dr. Brown has also completed additional coursework in functional medicine and has spoken at functional and integrative medicine conferences across the United States on the topic of laboratory testing. In his work with Genova's Medical Affairs Department, Dr. Brown enjoys consulting with practitioners from all medical disciplines and providing the support needed to help improve clinical outcomes. In his private practice, Dr. Brown helps athletes and active individuals to reach their highest level of health and performance through his advanced clinical approach. One of the most common questions that is asked during the webinar is about the availability of the presentation and the slide deck. These materials will be available on our website within a week of the webinar. If you are interested in having these resources, please click the Clinicians tab on the homepage, where you will find access to our webinars under Medical Education, or you can also log into your MyGDX account to find these webinars. And if you don't have a MyGDX account, just click the Getting Started link on our homepage and follow the instructions to set up an account. I'm going to now turn the role of presenter over to Dr. Warren Brown.
Thank you, Dr. Powell. It's great to be here. It's great to be with you all. All right. Well, once again, thanks, everyone. Thank you, Dr. Powell. It's great to be with you all here today, speaking on a topic that's really one of my favorite things to talk about in lab testing. Here's the overview for today. We'll talk about the relevance of nutritional testing for athletic patients. We'll discuss some functional and some direct biomarkers that tell us about nutritional assessment for our patients. We'll touch on some key areas where athletes often have deficiencies, so we'll present those in the cases, and we will present a NutrEval case and an ION case today. This is just a friendly reminder before we get started that we have to be mindful of the big picture and always acknowledge where our patients are in terms of their health status. So just a reminder to use our best clinical judgment, not forget about the basics when it comes to patient care. Nutritional assessment is part of the patient story. It's a big part, but it's not the only part. So just always a gentle reminder to think about the big picture with our patients. You may have seen this last month's National Geographic. There was an excellent write-up from journalist Christine Brennan. The cover story here was Building a Better Athlete, and it outlined some of the cutting-edge science and technology that supports elite athletes. And there were two quotes from the article that really stood out to me. The first one was from Alan Ashley, the U.S. Olympic Committee's chief of sport performance. And he said, in terms of breaking performance barriers, the key is to keep athletes healthy. And if they can stay healthy, everything else falls into place. I think that's a good thing to keep in mind when we think about these functional approaches that are targeted towards health rather than in that disease framework. So keeping them healthy, being preventive, I think those are important things when dealing with athletic patients. One of the leading researchers in the field, Peter Weyand, also mentioned that nutrition was among the key areas where research is headed in this field in terms of gaining performance and getting the most out of athletic performance for patients. I won't spend too much time on this slide or the next one. I just wanted to set the stage here, so to speak. We know the margins of victory are exceedingly narrow for our higher level athletes, and there's not much that separates someone who's a top performer from someone who's a mediocre performer. So We also want to keep in mind that these athletes face a lot of pressure to perform. And if we can identify and address inhibited biochemical pathways in our athletic patients, can this make a meaningful difference in performance and longevity? And I'd say the answer is yes, absolutely. That at least has been my experience in treating many athletic patients. And it's not uncommon to work with someone and then hear them say, yeah, I ran my fastest mile, or I feel like I've got more endurance than I've had in years, or I've got more mental clarity when I'm performing. So those kinds of things are not uncommon to hear when we address these weakened biochemical pathways. So athletes look healthy. They're often in great shape physically, at least in terms of appearance, but they don't always present that way biochemically. And so we do need to go deeper for these patients. And they're often motivated, they're dedicated, they're performance oriented. So they're interested in this type of information. This type of information that we're going to see in the NutrEval or the ION is way beyond what we're going to see in something like just checking a serum B12 or just checking CBC. This is the next step. This allows us to go deeper into these biochemical pathways. Add on to that most athletes don't have a whole lot of I'd say knowledge about nutrition and how to get the most out of their body. And they're often getting information from the internet or from media, from friends, from coaches. These really aren't qualified nutrition professionals. And I think we can do better, and we can be more scientific with our approach. And some of them even just experiment with supplement and diet. And that experimental approach is it's not less than ideal, I'll say. So we can do better. And when it comes to building that nutritional profile for patients, it's a combination of subjective information, what's their diet like, also what we're seeing in objective information. And in terms of subjective information, diet logs can be a good way to get a sense of exposure. I like to call it exposure. It's how exposed that patient is to the nutrients in their diet. But it doesn't tell us much about assimilation, how they're extracting those nutrients from the diet, how they're making it into the body. So it's limited in information that way. Diet logs can be time-consuming to interpret. Even a 3-day diet log can take some time. Useful information, but it does take some time to interpret. I typically use a 24-hour recall where I ask them what they had for breakfast this morning, what they had for dinner last night, what they had for lunch the day before. And I combine that information with my objective information to round out the picture. And in terms of objective nutritional assessments, we have two choices here, the NutrEval or the ION. And both profiles will provide comprehensive information about nutritional status. They'll answer a lot of the same clinical questions about the patient, and they both require blood and urine specimen. And we can see here in the graphic to the right here that they both have organic acids, amino acids, fatty acids. They both have nutrient elements and toxic elements. They both measure CoQ10 directly. And some of the fat-soluble vitamins, there are subtle differences in the way those are assessed. In the ION, they're more direct. In the NutrEval, they're generally more of a functional assessment. We also have some oxidative stress markers that are helpful for looking at a patient's exposure to oxidative stress, and that includes lipid peroxides and 8-OHDG. One of the key differences, though, is that in the ION we get homocysteine. In the NutrEval, instead of homocysteine, we get glutathione. And we also have the opportunity to add on a few genomic add-ons to the NutrEval as well. So that seems to be, in talking with a lot of different clinicians out there, those bottom two rows in this graphic here are really where most clinicians will make their decision about which test to choose. Let's talk a little bit about some concepts here. One is when we're looking at direct indicators of nutritional status, these are fairly straightforward. It's vitamin D, for example, or CoQ10, for example. We're measuring it directly. If it's low, we support it. Very simple. However, functional biomarkers are a little bit more, there's a little bit more to them in terms of the interpretation. And they work a little differently. And instead, they're telling us more about biochemical pathways. And they work like this. If we have intermediate A, intermediate B, and intermediate C in a given biochemical pathway, we know that there are enzymes that drive those conversions within the pathway. But they do have nutrient cofactors. In this case, for enzyme 2, there's a nutrient cofactor there that, if it's absent, may lead to a buildup in intermediate B, and we may see greater amounts or higher concentrations show up in urine or blood. Many of these analytes found in the NutrEval or the ION are going to operate on this concept. I like to try and make things as simple as possible, and let's use the omega-6 pathway, for example, here. If we know the elongase enzyme plays an important role in this pathway, and we also know that it has nutrient cofactor requirements, things like B vitamins and vitamin C. If those nutrient cofactor requirements aren't being met, sometimes we can see higher levels of gamma-linolenic acid show up, and we can see poor conversion into dihomo-gamma-linolenic acid. So sometimes we'll see DGLA low if we're seeing a buildup of gamma-linolenic acid. And then we think about the nutrient cofactors that are required to support that elongase enzyme. That brings us into our first case of the day. And our first case, we're going to talk about a NutrEval here for a 21-year-old female soccer player. She's a college student. Her chief concern was feeling wiped out after practices and games. She felt like her energy wasn't what it used to be, and that she was sort of headed downhill in terms of energy production. She had occasional loose stools, especially around game times. Her conventional blood work was normal. Her complete blood count, her comprehensive metabolic profile, iron panel, other conventional labs were all normal, and a pregnancy test was normal. And then we see her diet. She was on the college cafeteria plan, so she eats vegetables. She didn't admit to that. She aimed for 30% protein, 40% carbs, 30% fat. And she occasionally had some packaged foods in the diet as well, some convenience processed packaged foods. Supplements were a multivitamin and mineral. Medications were non-steroidal anti-inflammatories, which she took about 2 to 3 times a week for pain. She had moderate stress, mostly around exam times or game times, and she reported sleeping only about 6 hours per night on average. When we look at the first page of her NutrEval, we see quite a few borderline needs and high needs here. So I think the CoQ10 sticks out to me, and anybody who's reporting fatigue, things like that. The B vitamins look like a highlight here, as well as magnesium and vitamin D. And we'll dive a little bit deeper into that as we go through this test here. The next page of the NutrEval, we're looking at the suggested supplement schedule here, and what also sticks out to me here is that the omega-3 needs were high, and there were some digestive support recommendations made. We also see on that same page that there were several amino acids recommended, some at not all that high of doses, but there were quite a few amino acids needed here. Then when we look at this pattern, it's kind of our first clinical pearl of the day. If we're seeing digestive support recommendations in the yellow or the red status, if we're seeing several amino acids recommended, if we're seeing a patient who's reporting gut symptoms, in this case loose stools, then I think it's a good time to consider a stool test for more insight into digestion and absorption. Something like a GI-Effects Comprehensive or a CDSA 2.0 can be helpful in these scenarios for looking at markers that tell us about how well they're making enzymes and if there's excessive fat or protein products present in stool. Those kinds of things can be really helpful. This is just one shot of the interpretation at a glance pages here in the NutrEval. And what I like about these pages is that we list a nutrient here, we list a need, in this case a borderline need, and then we look at the last bullet point under the category and we see some food sources here. And those can be used to help remind patients that we get nutrients from foods. And I find those particularly helpful in patients who don't have that great a diet to start out with. These cues that we can circle on the report and hand to them can be really helpful for guiding those patients. Looking at the Krebs cycle page in the NutrEval here, this is just a clipping from the top half of that page. And we're looking at how efficiently macronutrients make their way into acetyl-CoA. And what I see here is carbohydrate movement into acetyl-CoA, which is glycolysis, looks to be efficient here because we're not seeing excess pyruvic acid, we're not seeing excess lactic acid. Things are moving pretty efficiently into acetyl-CoA, carbohydrate-wise. In terms of fats, that blue arrow is telling us about beta oxidation. And if we're seeing elevations in subaric or adipic, then we're thinking about somebody who's not, whose beta oxidation pathway is not optimal. So things looking pretty good up top here for this patient. Once we get into the citric acid cycle, there are some signs of inhibited pathways here, and the malic, the citric, the isocitric, we're seeing buildups in all of these. And these are intermediates in that citric acid cycle. So if they build up, it's a sign that there's trouble converting from one step to the next. And as we see here in the green circles, those are reminders of the nutrient cofactors that are required to support the conversion from one step to the next. And then we see in the red circles some inhibitors of those pathways. So this could be a sign that this patient has more difficulty making electrons for energy and making ATP. Brings us to the metabolic analysis markers page here in the NutrEval. And we're looking on the left side here at some dysbiosis markers, some malabsorption markers. The first one that we see high there, phenylacetic acid, that can be made when gut bacteria ferment amino acids. And that's a sign that if protein's not completely digested and absorbed in the small intestine, and it makes its way into the large intestine, bacteria can metabolize it in higher amounts. We also see benzoic acid. That's a general marker of dysbiosis. Then we see things like, in this case, arabinose and citramalic. And both of those can suggest the presence of yeast. However, phenylacetic acid, benzoic acid, and citramalic acid, they can all be influenced by the diet. So if you've got a patient who's consuming a lot of berries or grapes or other fruits, then that could mean that that's important to keep in mind when we're interpreting. Things like citramalic can be, arabinose can be influenced by artificial or by sweeteners. So somebody's got a lot of sweets in the diet, that may be related as well. So this patient wasn't consuming very much fruit and had gut symptoms. So suspicion here is a little bit higher for dysbiosis. And the probiotic recommendation seemed reasonable. The 5-hydroxyindoleacetic acid on the right-hand side here, may be a sign of unmet needs for B vitamins, magnesium, and manganese. All of those nutrients play an important role in tryptophan metabolism, which 5-hydroxyindolacetic acid is a metabolite of tryptophan and ultimately and serotonin as well. There are some more metabolic analysis markers here. We're seeing alpha ketoglutarate, or really any of the alpha keto acids here are pointing towards unmet needs for B1, B2, and B3 primarily. Glutaric, more specific for an unmet need for B2 when it's high. And 3-hydroxyisovaleric suggests an unmet need for biotin. MTBE, that is a gasoline additive. The alpha hydroxyisobutyric, for instance, comes from MTBE, and most people get exposed to that through water or vehicle exhaust. It's fairly common toxicant that we see. And when we see that, we think about how do we keep those detox pathways open, make sure they're getting enough B vitamins, make sure their glutathione is good, keeping phase 1 and phase 2 balanced if we're seeing a lot of toxin and detox markers. When we get to the amino acids page in the NutrEval, remember she was getting about 30% of protein, or 30% of her calories were coming from protein. And I expected to see the amino acids a little bit higher. And anytime you're seeing that situation where a patient's bringing in enough protein, but their amino acids don't look very good, think about suboptimal digestion of protein and possibly even absorption of protein. And at that point, I think enzymes make sense, but I think also stool testing would be a reasonable follow-up as well. The rest of the amino acid markers looked okay, with the exception of urea, which was a little on the low side. That's something I usually see when the essential amino acids are low, and that makes sense to me because urea is a byproduct of amino acid catabolism. So if amino acids are lower, we might not see a whole lot of urea show up here. Another clinical pearl here is if we're looking at the omega-3 and omega-6 percentages at the bottom of each category there, we can get a sense of balance between these two groups just graphically here. And in this case, we see her omega-3s are at the lower end of the scale, and her omega-6s are at the higher end of the scale. And those omega-3s are very important for combating chronic inflammation, for supporting cardiovascular health, brain health, health of our cell membranes. There are a number of different roles that omega-3s play in the body, so we want to see those well represented. And in this case, we're seeing the omega-6s higher, which generally speaking are more pro-inflammatory, with the exception of dihomogamma-linolenic acid. This omega-3 index, it's usually reported all the way at the bottom right of the essential fatty acids page, shows us it's a marker of omega-3 status, and it tells us about, it's a cardiovascular risk marker essentially. And there was a study a few years ago that looked at over 100 or so German elite endurance athletes and found that only one of them had the omega-3 index within the target range, which is above 8. And the authors suggested that optimizing omega-3 index could be a potential therapeutic target for prevention of cardiovascular events, and they also mentioned that it could be beneficial in terms of brain function for athletes. And it's calculated by adding the EPA and the DHA together. Then we're looking at the omega-6s here. Generally speaking, they're pro-inflammatory, but there is one omega-6 that plays an anti-inflammatory role, and that is dihomogamma-linolenic acid. And this example probably looks familiar to you from earlier on, our highway analogy here. We're seeing somebody who's quite robust in gamma-linolenic acid, and then has trouble converting that to dihomogamma-linolenic acid. And there could be a nutrient cofactor reason why that could be the case here. When we look at the oxidative stress markers and vitamin D in the NutrEval, we see her glutathione looked pretty to see it above 1,000. Not very much oxidative damage from lipid peroxides and 8-OHDG, but her CoQ10 level was low. It was frankly low here. CoQ10 is an antioxidant. It supports energy production. Some studies indicated that it can help peak power production in trained athletes. And I think reason to consider support here. Vitamin D, some studies suggest that it can benefit athletes in a number of different ways, like lowering risk for stress fractures, lowering total body inflammation, helping support immunity, and even helping to support muscle function and the recovery from injury. So vitamin D important here, and she was low in vitamin D. The elemental markers here didn't look too far off the mark, but there was a high need for magnesium that we saw on the first page of the NutrEval. And that's in part based on the magnesium measurement here in red blood cell, but it's also in part based on some of the other magnesium-dependent pathways, like 5-hydroxyandilacetic, for instance, which is one of the many markers that weighs into that magnesium recommendation. We also see potassium a little on the low end, and that's something you might see fairly commonly in endurance athletes. They're sweating a lot, often for long periods of time, so that could be one aspect, but again, dietary intake could be another reason. And I've listed a few food sources here for potassium, foods that are high in potassium concentrations. I just want to pause 1 minute here to talk about why, we saw in this patient a lot of borderline needs, a lot of high needs. Anytime I see that in the NutrEval, I always think about what could be the cause of that. What's the root cause? Is it low dietary intake of nutrients? Sometimes that's the case, but it can also be poor digestion or absorption of nutrients. It can mean somebody who has a higher need or utilizes more nutrients, like athletes, for instance, patients who carry a lot of stress, patients who are on medications that deplete certain nutrients, autoimmune conditions, toxic exposures, and genetic polymorphisms. All of those could be potential reasons why we see high needs or a lot of borderline needs in the NutrEval on the first page. So back to this case, what do we do for a patient like her? Well, diet and lifestyle, always a good place to start. And she needed some help with her omega-3s. So incorporating more omega-3 containing foods in the diet, flax, walnut, fish, chia seeds might be something to consider as well. We want to get her sleeping 8 hours per night. She's fatigued. She's not getting enough sleep. So that needs to be addressed as well. We want to encourage stress management practices if she can, whether it's breathing exercises or heart math or biofeedback or yoga or any number of different lifestyle practices to help her manage her stress will be helpful. And I think it also would be worth considering the adrenocortex stress profile with the cortisol awakening response to look into cortisol levels. That may add some more clarity to her HPA axis. Also, she was taking a multivitamin. We want to switch her to a higher quality multivitamin, and we want to ensure that there's enough B vitamins and magnesium in there. We also think that vitamin D here and CoQ10 looked like they were frankly low, so supporting those levels seems very reasonable. And then a broad spectrum probiotic to deal with the dysbiosis markers, the digestive enzymes with her protein containing meals might allow her greater access to the amino acids in the protein that she's already consuming. Then we want to consider a GIFX comprehensive or a CDSA 2.0 if the loose stools persist, if the probiotics and enzymes aren't enough to give her relief in the next 4 to 6 weeks, then looking at stool testing would be a reasonable follow-up there. When rechecking the NutrEval plasma, around 6 to 12 months is a reasonable time to check into the patient's new baseline. All right, so that was the NutrEval case. This is the ION case for today. And we are looking at a 32-year-old male cyclist. He was a mountain biker, road biker. He did a lot of endurance mountain bike races, worked as a sales associate. His chief complaint was the bonk, diminishing endurance. He had a primary care provider that he was seeing, and everything was normal in terms of the conventional workup. But he was still feeling like his endurance wasn't what it used to be. And so his diet, well, he was doing a lot of high protein, had a lot of high protein foods. It was mostly animal based. He was supplementing with protein powders and sports drinks, things like that. So he was high on the protein intake, moderate on fat, and low carb, generally speaking. He wasn't eating a lot of vegetables either. And there were some convenience foods. He's someone who was always on the go, and so he was always looking for things that were convenience. Energy bars were in there. He also had, he was consuming 3 large cups of coffee a day, so a lot of caffeine too. He did report some gut symptoms. Mostly it was tending towards constipation with some occasional gas and bloating. Only having about 3 to 5 bowel movements per week, so he's more constipated. And supplement-wise, he was doing a whey protein powder on top of his high protein diet. He was doing sports drinks, and then he took a multivitamin. It wasn't regular with that multivitamin, so it was kind of sporadic use, but he was taking a multi, and he wasn't on any medications. He was carrying pretty high stress levels. 8 out of 10 was his average in terms of stress level, so he's pretty stressed, and he wasn't sleeping very much. He was about 5.5 hours per night. He would get up really early to do his training before work, and then he'd work a full day, and then it just didn't leave him much time for sleep by the end of the day. When we look at his amino acids on the first page of the ION, the trend here is high. Everything was in the 8 out of 13, in fact, of these amino acids were either high or in the 5th quintile. So very robust, and that's reflective of his intake of protein. We also see that same pattern continue on the second page, and here we're seeing most of these amino acids in the 5th quintile here. Then we get the homocysteine level here, which looked high normal. Homocysteine is a cardiovascular risk marker. This is the example, what we talked about earlier, about somebody who looks healthy from the outside, but not necessarily inside. In this case, looking at his cardiovascular inflammation here. So a high normal result that can be related to unmet needs for B vitamins and folate and things like that, but there are other oxidative stressors that can contribute to homocysteine. He wasn't getting a lot of vegetables in his diet, so he lacked the antioxidant capacity, I think, to help deal with oxidative stressors. Nothing abnormal here in the nutrient and the toxic elements here in the ION, but he did have low normal potassium, low normal magnesium, and that may be noteworthy in this particular case. Potassium levels, this is like the last patient we saw, maybe somebody who's doing a lot more sweating than the average person, and in this particular case, not taking many foods in that are good potassium sources. So it could be a combination of that. He's not low, but he is low normal here. Magnesium always catches my attention when it's low or low normal, even when it's low normal. And that's because it's a required cofactor for more than 300 different biochemical reactions in the body. So very important mineral, and when it's low normal, I think makes sense to try and support that. His fat-soluble vitamins here, CoQ10, alpha and gamma tocopherol, all those are vitamin E isomers, and then vitamin A and beta carotene all look pretty good here and probably reflective of the multivitamin that he was taking. Those are fat soluble, so they stick around a little bit longer before they wash out of the system. We also see some more evidence of oxidative stress with number 7, 8-hydroxy-2-deoxyguanosine. That is a marker that tells us about oxidative damage to DNA and suggests that he needs more antioxidant support. Studies have been kind of mixed on whether or not there's a performance benefit to addressing 8-OHTG. So it's one that when we see it high or high normal, we still want to support it just for the sake of overall health and longevity. The bigger story on this page is actually his vitamin D, which was very low. It was 18.7, so some support needed there. It brings us to the fatty acids page in the ION, and we're looking at omega-3s, 6s, and 9s here. And if we look at his omega-3s, everything was in the 4th quintile or lower. And when we look at the omega-6s, most everything was either in the 4th quintile or higher, and that applied for the omega-9s as well. So this is someone who's not getting as many omega-3s in as needed, in my opinion. I often call the omega-3s the forgotten acids, because athletes are always focused on getting enough protein, making sure their carbohydrate intake is appropriate, but they forget about fats, and they forget about omega-3s in particular. The monounsaturated fats and the saturated fats is kind of a similar pattern. If we look at where those black diamonds are on the scales, generally we're seeing the monounsaturateds a little on the lower end and the saturateds a little bit higher. It's not a huge pattern here that I'm seeing, but it looks to be a general pattern. The monounsaturated fats are those that are common in the Mediterranean diet, things like olive oil, fish, avocado, macadamia oil, for instance, monounsaturated fat. And the saturated fats are typically coming from animal products. Usually it's dairy or fatty meats, things like that. So maybe a little bit of imbalance we're seeing here as well. We're looking at fatty acid metabolism and carbohydrate metabolism on the Krebs cycle page in the ION, citric acid cycle. And up top, I'm seeing fairly efficient conversion in that beta oxidation pathway based on the adipate and the superate. Carnitine is something to consider when you're seeing ethyl malonate elevated. In this case, just a high normal finding here, but it may be a scenario where some carnitine and B2 might be helpful here. In terms of carbohydrate metabolism, things looked good here. We weren't seeing elevations in pyruvate or lactate. I'm okay with seeing beta hydroxybutyrate less than detectable limits. That's a ketone body. So things are looking pretty good here. More notable was the energy production citric acid cycle markers here. And here we're seeing number 10, alpha-ketoglutarate high. And its next step is the conversion to succinate. And that is a conversion that happens with the help of a dehydrogenase enzyme that requires B vitamins and lipoic acid to help convert alpha-ketoglutarate into succinate. And ultimately, this is about energy production here when we're looking at these citric acid cycle markers and how well we can make electrons. When we're looking at these B complex markers, these are some other places in the report where B vitamins play a role. And if you're seeing an elevation in xanthurenic or beta hydroxy isovalerate That could mean that there's unmet needs for B6 and biotin, respectively. Those are B6 and biotin markers there. I also think it's interesting because of what we saw earlier with this patient. He had a high normal homocysteine, and here we're seeing a form amino glutarate, or FIGLU as I often call it, a FIGLU that's building up. So there may be some unmet needs for folate here as well. He's right at approaching the 80th percentile for form amino glutamate. When looking at the neurotransmitter metabolites, these give us some insight into the neurotransmitter pathways, which often have cofactor requirements for B vitamins, and things like B6 play an important role here, but also some minerals like magnesium and copper, things like that. So if we're seeing abnormals here, then it's worthwhile thinking about those nutrients for support. Vanilmandylate in particular is a catecholamine metabolite. Its precursor from an amino acid standpoint is phenylalanine or tyrosine. And if we're, those amino acids were fine in this patient. His amino acids were actually all on the higher end. So I don't think it's a precursor issue why we're seeing low levels of vanilmandylate. I think this is probably pointing more towards unmet needs for B vitamins or minerals. And those B vitamins and minerals play a role in the production of kynurenate and quinolinate as well, and particularly for B6 in those scenarios. Those are tryptophan metabolites. And then we see number 29, again, this is the same 8-hydroxy-2-deoxyguanosine we saw earlier in the report. Just a reminder that it's an oxidative stress marker. Detoxification indicators for this patient, I think, look good overall. He's looking pretty good here, so I'm not seeing anything high. The glucarate didn't look too noteworthy. Everything else in that section was normal. Things are looking pretty good there. When we get to the dysbiosis markers here, last section in his ION report here, I was expecting to see some signs of dysbiosis here, due to his, he was more constipated, he had some bloating, but things looked pretty good here. Everything was in the normal range here in terms of these bacterial and yeast dysbiosis markers here. So doesn't mean that there's not an inflammatory reason why he's got gut issues. There could be, and that would be a scenario where stool testing would be helpful in providing more insight into that. But at least in terms of dysbiosis, things looked okay here. In the ION, you will get some nutrient recommendations here, and these are some of the things that we talked about as we were going through. Vitamin D, B vitamins, magnesium, CoQ10, lipoic acid. What's interesting about that CoQ10 is that his level looked pretty robust in the fat-soluble vitamins, but there were other coenzyme Q10 dependent pathways, like, for instance, the citric acid cycle markers, where CoQ10 may be helpful. And symptom-wise, that made sense to me. He was more fatigued, and he needed that endurance. So maybe maybe not a strong need for CoQ10, but maybe some additional support worth considering. When we put together this treatment plan for this patient, we're going to get the most benefit out of these areas, in my opinion here. And so, looking at diet and lifestyle, he had a lot of protein in the diet, and we want to incorporate some more colorful fruits and vegetables in there. We also want to increase his dietary fiber. He was consuming a lot of coffee, so we won't take him completely off coffee, but we will try to get him to make a little shift towards green tea as a substitute for some of that coffee. Green tea has a lot of antioxidants in it, and he did have some oxidative stress markers that were a little borderline. So makes sense there. We also want him to aim for 8 hours of sleep per night. That's going to be difficult for him to do given his schedule, but That is the goal, and we made that clear. We also want to incorporate some stress management practices in for him. Those would be things like we talked about with the last patient, whether it's breathing exercises or yoga or heart math or biofeedback, any number of practices where he can incorporate some more mindfulness and deal with those high stress levels. If somebody's carrying a lot of stress, they're going to be more catabolic. It's going to be harder for them to maintain bone mass, maintain lean mass if their cortisol levels are really high. So we want to deal with that, and sleep is part of that. But if we want more information in that, the adrenocortex stress profile with the cortisol weight gaining response, also with melatonin for this patient, I think makes sense, which is an add-on for that profile. That'll give us more insight into his HPA axis. We also want to think about things like vitamin D, antioxidant support, and a B complex. All of those made sense based on the markers we were looking at in the test. He was low in vitamin D. His antioxidant status was likely a little bit lower, and he did have several markers that pointed towards needs for B vitamins, so we just go with the B complex in this case. We also want to switch his protein powder from just a straight whey protein to one that has that's maybe a protein with a multivitamin incorporated into it, so he gets it on a more regular basis, because that was a route that he was regular about his protein powder. So if we can incorporate some multivitamins into that and maybe reduce the amount of protein just by a little bit, we might do him some benefit there. Also, considering a GIFX comprehensive, we saw his dysbiosis markers were fine, but that doesn't mean that he has some chronic inflammation that's that could be there. So the GIFX or the CDSA 2.0 might be helpful there for identifying that. Follow-up for the ION, similar to the NutrEval, around 6 to 12 months is a reasonable time to repeat an ION profile. So what did we just do? We talked about the relevance of these nutritional profiles for athletic patients. We talked about some functional biomarkers and some direct biomarkers for assessing that status, and we also identified some key areas of nutritional support for athletes. We saw vitamin D low in both of these athletes. We saw needs for B vitamins, needs for stress management, those kinds of things. So a lot of different areas where athletes commonly need support. And we also interpreted an ION profile and a NutrEval profile. I have a couple of other considerations here that might be worth considering here. The NutrEval or the ION, it's really either or, and I recommend if you pick one and you do a follow-up, stick with that same one. It's just easier to compare the results from a initial to a follow-up in terms of the profiles. Also, we saw that that there are some differences between those two profiles. If you're more interested in looking at homocysteine, lean a little bit more towards that ION profile. If you want to see glutathione measured directly, lean a little bit more towards that NutrEval profile. I also wanted to mention sporting rules and regulations here. If you're working with high-level athletes who get tested, just double check your recommendations, make sure they're not on any banned substances list for that athlete. Most athletes know what's banned and what's not, but if you were following up with an adrenocortex stress profile and you saw DHEA low, DHEA is a banned substance for most organizations, so it would just be something to consider before you provide that. So just check your recommendations, and also route of administration. Some things like IVs can be prohibited by certain organizations. So just double check those recommendations to make sure you're in alignment and we don't get our athletes in trouble. In terms of the starting with an ION or a NutrEval, and trying to figure out what Genova profile might make sense as a next step. I've outlined some notes here, and if, for instance, how this works is if we're looking at the upper left or the upper left-hand side, and we run a NutrEval or an ION, and we see strong probiotic or enzyme recommendations, we see things like malabsorption or dysbiosis markers elevated, dietary peptide-related markers high, or amino acids low, then a GIFX comprehensive or a CDSA 2.0 may make sense as a follow-up, because that will give us insight into bacterial populations. It'll also give us insight into how well that patient's digesting and absorbing that protein, how much pancreatic elastase they're making, those kinds of things. So that can help us based on what you're seeing in the NutrEval or ION, point you in another direction. We also have at Genova a team of medical education specialists who can help assist if you're wondering which profile to pick to start with or as a follow-up. We can help you with that. You can give us a call and schedule some time with our medical education specialists. And I also take calls as well. So you can give us a call, and we will be happy to talk about test results or profile selection, those types of things. I've included a couple more resources for you here. These are just links to a lot of resources online that you can access for free that I use regularly when I'm interpreting the tests and also when I'm applying the results. So a lot of good resources there. And that brings us to our question and answer session. I want to thank all of you for taking the time out of your day to join us. I also want to thank you, Dr. Powell, for facilitating today.
Thank you. Thank you. That was a wonderful presentation. We did have quite a few clinical questions from a few different folks who's attending our webinar today. So let's start with this one. What is the difference between the NutrEval FMV, or first morning void, and the NutrEval plasma?
A good question. The NutrEval, the difference between those two types of NutrEval is going to be in the amino acid assessment. And when we're looking at a NutrEval FMV, that amino acid measurement, those amino acid measurements come from the urine portion of the specimen. And when we look at the NutrEval plasma, those amino acids are coming from the plasma portion of the specimen. So the difference between those is plasma gives you a little bit longer time frame, around 3 weeks or so. And the NutrEval FMV is, we're looking at an amino acid status of around a couple days. So that's the main difference. For athletic patients, I like the NutrEval plasma. We do sacrifice a couple of markers in the dietary peptide related marker section, but I think the trade-off is worth it because of that more steady state when it comes to the amino acids. So I'm both good profiles, and we always say that if the patient has an inconsistent diet, they're better off with a NutrEval plasma, because that will sort of average out the highs and lows for the aminos over a longer period of time.
Which genomic add-ons for the NutrEval do you like most for your athletic patients?
Well, for the NutrEval, we have 4 choices. There's COMT, MTHFR, ApoE, and TNF-alpha. And I like COMT, MTHFR. I like them all. ApoE is one I pick more. I'm more inclined to pick that if a patient wants to try a ketogenic diet. I just want to make sure that their ability to metabolize lipids is appropriate. So I think the ApoE is maybe conditional there, but the COMT, MTHFR, and TNF-alpha are all worthwhile. TNF-alpha is going to tell us about the potential for cytokine production. MTHFR is going to tell us about the importance of folate metabolism in the homocysteine cycle. And then COMT is going to give us information about how well they're metabolizing catecholamines. estrogens, toxins, things like that. So I think they all have value. ApoE, I'm more inclined to pick that one if the patient's interested in trying a ketogenic diet.
Okay. And can you elaborate a little bit more about the genetic SNP add-ons? How do you leverage that information when you're trying to arrive at recommendations for nutrient support for your patients?
Right. A good question. The genomic add-ons I find really helpful for understanding the why behind the patient might have, higher needs for B vitamins, for instance, or, they might be taking a multivitamin and they still might have increased needs for B vitamins. If we can look at MTHFR and COMT and see how well they're methylating or see their genetic predisposition for methylating, that can sometimes help us understand why we might still be seeing needs in a patient who's supplementing. I also feel like it's really helpful for conveying that some aspects of the treatment plan may be more of a long-term strategy because there is a genetic predisposition for something that won't change. So things like if somebody's not methylating well, B vitamins may be more of their long-term plan rather than just a short-term plan.
Thank you. At the end of the first case, you listed several different conditions or underlying factors why a patient may have an increased nutrient need. For example, low intake, digestion, absorption impairment, increased utilization. How do you typically assess or further assess for these different factors?
That's a good question. In that slide, dietary intake, I prefer the 24-hour recall to get that subjective information. Digestion and absorption, a GI Effects Comprehensive or a CDSA 2.0 is a really great tool for that. Stress, which can deplete us of nutrients, particularly the B vitamins. I like the adrenocortex stress profile with the cortisol awakening response for that. If there's autoimmunity, typically I'm relying on my conventional workups for that. If they've got thyroid antibodies and thyroid issues, Genova offers a comprehensive thyroid assessment that provides a really nice picture of that. That may be worth considering. But if there are other types of autoimmunity, then relying on a conventional workup for that. Toxic exposures. Those are, so if I'm thinking metal toxics, then I'm thinking comprehensive urine element profile. But if I'm thinking non-metal toxins like pesticides or PCBs, things like that, then something like a toxic effects core may be worth following up on. And then in terms of the genetic polymorphisms, you could go with the SNPs in the as an add-on for the NutrEval, or you could run something like a detoxigenomic profile, which will look at phase 1 and phase 2, which athletes often have issues with oxidative stress and issues with some of the nutrient cofactors that really slow down those pathways. So I think a detoxigenomic profile is probably the one that I lean on the most.
Thank you. So in the interest of time, we will end our question and answer period there. For additional education materials, we would like to encourage you to visit our website, www.gdx.net. On the site, you'll find sample reports, kit instructions, and more information for each of our profiles. After taking advantage of the materials found on the website, you can go ahead and contact client services with additional questions. You will see a contact number on the slide for US and UK customer service. Additionally, please call client services if you need assistance in setting up a MyGDX account. Also, we offer complimentary appointments with our medical education specialists to answer questions related to our testing, including choosing the right test and reviewing patient test results. Finally, we'd like to encourage you to register for our upcoming webinar on www.gdx.net. Next month, we will have Dr. Elizabeth Board presenting on functional medicine approach to osteoporosis prevention and treatment. Thank you again, Dr. Brown. That was an amazing presentation. I appreciate it.
Thank you, Dr. Powell. Thank you. Thanks, everyone, for attending, and thank you, Dr. Powell.